We're going to kick this off, everyone. Look, this is a slightly unorthodox thing. We've not done this before. I don't know how long it's going to last. It could be 5 minutes. It could be 10 minutes. It could be half an hour max. Brian and I decided about 9 months ago to come up with, try and come up with one statement, a consensus type statement in one of the cancers. And we had a quest. We asked the faculty what we should do, and we kind of couldn't come to an agreement. Anyway, we decided if we could move to the next slide, that'd be great. We decided to try and define oligometastatic disease in kidney cancer. Do we need a definition of oligometastatic disease, number one? Yes or no? And if we do, then what is it? And we were going to try and see if we could decide that today. We're not going to vote via, we're going to vote via our hands. I quite like the idea of accountability in consensus statements. So we're going to do some voting if we can. I don't know if I can move to the next slide. I don't know if it's possible. That would be great if we could. I'm going to start by asking the panel, if I may, and Tian, I'm going to start with you. Brian and I came up with a definition of oligometastatic disease. If we could move to the slide and show what that is, it would be brilliant. If we can't, it doesn't matter, because I'm going to try and make it up. The definition that we came up with was, I think, 3 components. I think sites of disease and disease burden was relevant. We also felt that potentially the IMDC classification had a role to play. Poorest disease couldn't be oligometastatic. And then the number of tumor sites were the 3 things that we came up with. We had a debate about whether time from surgery or duration of surgery or duration of disease was relevant. And then we came up with a statement which, can we show the slides? Is that possible?
So Tom, in your discussion, because it's very timely, many people are working on this right now.
Yeah.
Did you take into consideration also the attempt of render the patient NED, or the fact that you're going for focal treatment only and not necessarily systemic therapy? Does the treatment itself was taken into consideration when you move on with your definition?
So the conclusion after initial discussion we had was it should be not a clinical, but a treatment-related definition, because that's why it's useful. Because having a definition of oligometastatic disease isn't that useful in itself, but if you'd said this defines patients that don't need to start systemic therapy, that can have local therapy, that should be the definition. And the first question that I wanted to ask was whether or not that is something that we as a group can agree on. Tian, what do you think about that? Would it be useful is it useful and possible to define a group of patients?
Yeah, I think the question is, could your intent to treat sort of encompass in one field, right, be that disease-defining entity so that we, give definitive treatment for oligometastatic disease? Or is it a harbinger of microscopic systemic disease that we really need systemic treatments? So I commend this effort to figure out who are the right patient populations. I do think the treatment matters. So if there are people who have oligomets in one radiation field, for example, that might make a lot of difference than like 2 separate, completely different sites of disease. 1 bone met and 2 lung mets are probably different in biology than 3 nodules in the lungs.
Hans.
I like what you said, which is that that it should be related to how we would approach that disease, right? And to me, when I hear the word oligo, it means it's just a few, meaning we can just do focal therapy, right? Either surgery, radiation, etc. So I think that's a critical point. So for me, it's really about what have you learned over the past decades, quite frankly, about which are the best surgical patients, quite frankly, right? And I think that will guide us how to think about oligo, meaning that a patient who has site-directed therapy, focal therapy, can derive long-term benefit without systemic therapy, right? That's how I would look at it.
Florence.
Yeah, and that's the idea we're discussing. To me, it's a patient that does not require systemic therapy up front. We can debate after about the pseudoadjuvant. I also associate that with a more favorable prognosis in my head. And so I agree that we need to come to a consensus in how we define that.
And Tony?
I think it's useful, very useful. I am not sure it's possible to define it.
So we can agree it would be useful to define it, but we're not clear we can define it. Is that where we currently are?
Here.
So can we agree as a group, we show of hands, say that if we are going to define oligometastatic disease, it should be defined as those patients who don't need systemic therapy, who can have a local
No, we don't
He's
have
been
slides.
trying.
We
He's
don't
been
have
trying
the
to
slide.
get
We don't have the
slides,
slides.
but
We're trying to get slides. But Brian, maybe you could help with that. Or Brian, maybe you could go and type something. Like, might be nice if we're going to do so, is it possible to type something on the screen as we're going along? It's like having a blank slide so we can kind of type something as we go, if we can define it. That's possible. Would you like to do that for me, Brian? Thank you. Okay. So Brian, or Petros can do it. Petros, why don't you do it?
Yeah, Petros.
Yeah, Petros, you do it. Yeah, great. Petros. So
Baklava.
that normally only happens after Uzo.
yeah, here we go.
Oh, okay.
So do we need a definition? So this is our slide. So the answer is we're going to vote on a definition now, which is patients who are potentially amenable to local therapy. Who thinks that's a fair definition? Okay. And who thinks it's not a fair definition? Yeah. Oh, no, we're coming to that in a second.
Well, you're very prostate. That's why you need a number.
We're going to come to a number.
It's hard.
Okay. So Petros, could you stick with us? Because what I'd like to do is I'd like you to write something down which defines it. So this is our definition. Oligometastatic defines a group of patients who are fit enough for systemic therapy, but where the pace of disease and the number of sites of metastasis are amenable to surveillance plus or minus local therapy. Are we agreed with that statement?
Yes.
Does anyone disagree with that statement? Mike, you disagree. It's only one. It's about 5%. Do you want to explain why, Mike?
Because you're going to want to give adjuvant therapy to these patients after the surgery, you should give the therapy before the surgery because you learn so much more about whether the treatment works.
You mean neoadjuvant?
Yes.
So you are a pro-neoadjuvant.
Very much so, yes.
Where is Dave McDermott?
Okay.
Not
he
the
is
primary.
He is here.
For the metastatic disease, not the primary
So,
disease.
Mike, we take your point about drug development, but the consensus, about 90%, maybe 94% of people felt that that definition is fair enough.
So I'll stand by my statement that those patients should get systemic therapy. You should remove the systemic therapy, not getting systemic therapy from the definition.
Thanks, Mike. Tian, I'd like you now to try and define what this group is and work out if that's possible.
Well, I think what we struggle with is the clinical judgment, right, of who in that group of patients can wait, or, to Mike's point, have a defined course of systemic treatment before they get definitive localized disease. But the goal is the same, is that we want to make sure that all sites of disease are well treated.
So is it only one organ that's affected, or could it be more than one organ? That would be the next question that I would ask. One or more organ?
Yeah, and I struggle a little bit with this. I think if it's more than one organ, then there may be things in between, right, that are microscopic that we can't see. And so those are the folks that I would favor an approach like Mike's, where we do some systemic therapy, then give their definitive local treatment.
So what I was hoping is the four of us could agree on something and then we'd vote on it. Because if the four of us can't agree, there's no one else is going to agree. So can we agree that it's more one organ, or are there scenarios where it could be more than one organ? That, I think, is probably the easiest question to answer.
In
Hans,
general,
do you think
one
more?
organ?
Do you think more than one organ? Say liver and bone, or
Up to
lung
two.
and up to two.
I actually agree, up to 2.
Up to 2,
Yeah. Yes.
including liver.
Yes. because
Liver
you can
and bone
do-
metastasis.
And bone and brain.
Liver
I
is
wanted to
radiology.
say it should,
Shilpa, let's say Shilpa.
I would be hesitant to include visceral mets in that. Would be excluding liver for, like someone with a liver met, we don't want to Just
I would like to
surveillance.
vote on Shilpa's point because I think it's, let's see if we can agree. So up to 2 organs, but no visceral metastasis. Is that fair?
But
So
lung
I'm
is
not
visceral.
comfortable because I agree that I'm okay thinking about 2 organs or 2
Yes.
sites, but we don't have any data to back that up.
We're gonna
in terms
struggle.
of prognosis, and this is something that we could do because it's not the same to have only one site than have several sites in terms of prognosis.
So one of the issues with consensus kind of statements is you'll often be in a position where you can't find data, and we may never generate that data. And then, so sometimes it's worthwhile having it, and sometimes you just say, look, let's go to the break. We're not going to win here. And I'm very happy to do that. But can we come up with a, because if this is a non-starter, if we can't get to the point where we can't even agree on the site to define this, then we're never going to get to all of the other complications of duration and IMDC and all these. Is there a site that we can agree with? Is it 2 sites and the Shilpa amendment with no visceral metastasis? Can the 4 of us agree on that or not?
Lung would be an exception because like Brian and others
So
have
lung
shown.
and lymph node?
So if we
Yes,
exclude
but
liver,
not
which makes sense from a prognosis standpoint, then
Yes.
we exclude bone.
Exclude liver, exclude brain, exclude bone?
Yeah.
I can live
Hands?
with
I
this.
think that's true.
Can you live with exclude liver, brain, bone or not?
No,
No.
Like I do think there are patients who can have limited bone-based disease, and I don't think that's right.
Could you exclude liver? Will you agree liver?
By the way, the person who is missing here on the stage is actually a good surgeon who used to do metastectomies for decades, right, at some of these institutions like in Cleveland and other places. So they actually have, there's all this experience with these surgical series where they carefully selected patients.
But you're not cutting out liver mets.
I have radiated 1 or 2 liver mets with sometimes good success, but I don't have the overview of large data sets, quite frankly. So I would not necessarily exclude it if it's like a single liver met at some point. Well, it depends on. Well, so we are trying to define the oligo patients which may benefit from that. So if you have, like, say, 4 or 5 years in a single enhancing liver met, I would probably just address it.
Can I put it to a vote to the group because we have got stuck here.
Yes.
We have got stuck. So we've got a potential break coming up if we're lucky. So what I'd like us to vote on is the following. I'd like us to vote on whether oligometastatic disease can be defined as up to 2 organs, but not involving the liver, brain. I'm allowed to keep bone in. And we're going to vote on it. I know you are, because you can vote against it. I'm happy if you do against it.
Okay, so let's figure out a patient that has lymph node in the mediastinal, 1 retroperitoneal lymph node, and 1 tiny lung met.
Yes?
Okay, so
That's good to go.
That's 3 sites.
No, we said 3. Where's the other one?
Well, you have supra and infra diaphragmatic
No,
lymph
that's just
nodes.
lymph node. Anywhere lymph node.
No,
So
no,
lymph node is
no.
one side.
No one lump supra and infra diaphragmatic lymph nodes together. That's not one site.
So we can't agree on whether lymph node is one disease on one site or not.
Depending on the site.
Oh no, we have to agree on that. No, surely. No, we have to agree on that. So can we agree that lymph node is one site?
No,
No.
no.
Hands. Lymph node's one site. Help me here.
You're making it too complicated. We're going to go nowhere in this tempo. So
No, we're going to go nowhere. I agree.
yeah.
We can't define an oligometastatic disease.
And I told you.
I know you
Well,
just say that, but don't be too destructive.
there were 2
Oh, sorry.
radiation trials, right, that did
Sorry,
define
Chia.
them. They said 3 sites or less. I don't think they limited the organ type, but I could be wrong. There are 2.
But they also had no time component, which is
They
totally
had no
wrong.
time component either.
So I would just make it simple.
Okay, let's hear a new plan.
2 organs up to 3 lesions, period. I wouldn't go beyond that.
I'm okay with
And you
up to
can
3
start with that,
lesions.
then we can tease out this data
2
for liver.
organs up to 3 lesions.
Let's go for up to 3 lesions, period.
2 organs
3 lesions
3
in
lesions.
2
up
organs.
to 2 organs.
Tony, could you
And
help
you
me,
can
please?
choose which
3
ones they
organs,
are.
2 organs. 3 lesions, 2 organs.
2 organs, 3 lesions.
You happy with that? You'll vote for that?
I would.
Tian, will you vote for that?
Yes, and definitively treatable.
Yeah, would you vote for that as well? Because my thing is, if we can't agree, then it's hard to put it to the rest of the group.
But by the way, that's not by itself. There needs to be other
No,
components.
we're
in
coming
it.
to that. We haven't finished this yet. This is the second stage. We agreed we could come with a definition.
Okay.
Can we get the sites of disease? We're now going to vote on 3 lesions, 2 organs. Excluding liver and brain? No. No. No, Petros. Okay, we're voting on that right now. 3 lesions, 2 organs. Who thinks has happy with 3 lesions, 2 organs? 1, 2, 3, 4, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Who's not happy?
Always unhappy. The
1, 2, 3, 4, 5, 6, 7, 8, 9. Well, it's nowhere near a consensus.
Japanese never.
I mean, it's nowhere near a consensus. It's a disaster. Hans, you've been voted down, I'm afraid. So look, if we can't agree on that, is there an alternative? Does some of the people who vote against it, is there an alternative thing that we could vote on that might work?
Less than 3 lesions.
Less than 3
Or was
lesions.
it to exclude certain organs, to exclude liver and brain? I think that's what they wanted.
Okay, what about 3 liver? This is going to be the last vote. If we haven't got consensus on this, we're going for a break. Okay? So this is the last vote. If we get consensus on this, we can keep going. If you vote against it, get a break. No incentive.
I'm not sure that's helping to move forward because people want the break.
Yeah, so people want the break. So we're gonna voting on excluding liver, bone, brain.
Bone did not make
Liver,
a
brain.
consensus.
We're excluding liver, brain. We're
Liver, brain.
excluding liver, brain.
There's no reason to exclude the brain
3
also. I mean, there are patients who just had 1 or 2 lesions in the brain. You're ready, they never show
Hans,
up
you
again.
had your shot. You had your shot. We voted on your amendment. We had a go.
Whatever.
So, 3 lesions, 2 organs, excluding liver and brain. Who votes for that? Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Stephanie, thank you. 12. And who's voting against it? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, we're going for a break. We haven't reached consensus, everyone. What we have, before we stop, we did agree how the oligometastatic defines a group of patients who are fit enough for systemic therapy, but with a pace of disease, a number of sites, and means surveillance therapy, but we are unable to define what those sites are.
Correct.
So forget the sites for a second. We should talk about the pace of disease, so at least we can take the discussion.
Okay, let's have a vote. You can put up on a question, we'll vote on it. Far away, Hans.
No, what I'm trying to say is so to me it makes no sense to consider a patient who recurs within the first year as oligometastatic disease. That is not oligometastatic.
Okay, I'm happy with that. I can vote on that. I can vote on that.
Not
I will vote on
true.
that.
Not true. That's different than oligometastatic.
No. The time component is critical for oligometastatic disease.
Critical.
It's absolutely critical.
It's everything. Okay, we're going to vote on that, Tony, and please abstain. Please. Okay, so let's see if we can agree on one thing, only one thing, that if you progress within a year, your cancer's progress within a year of surgery, that does not define oligometastatic disease.
No, I disagree.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, and against? 1. So we do actually have pace.
Well, Tony, it's part of the IMDC
No,
criteria.
you've got to
right?
get 5%. You've got to have 70%, or 70% is consensus, and we've got 95%.
But Mike joined me.
Okay, sorry, Mike, I apologise. 2 versus 20, but it's still 90%. Okay, so we've got pace. We're not able to agree on site. IMDC classification. If you have poor risk disease, can you have intermediate or poor risk disease? Can you have oligometastatic disease? IMDC classification. If you have intermediate and poor risk disease, can you have oligometastatic disease?
I think it depends on which IMDC criteria.
You could, but less likely.
If it's like a little bit anemic, right? Maybe. But if it's less than a year from surgery.
So you're going to vote no on that? You could say you could have intermediate risk disease and oligometastatic disease.
Depending on which IMDC criteria.
So we're going to vote on this question. Good risk, so oligometastatic disease is by definition IMDC good risk. Who believes the answer to that question is yes? 1, 2, 3 is going to be bad. It's going to be really bad. Who thinks no? I apologise, Shilpa. I apologise. But we're going to lose this anyway by miles, because we're miles away from consensus. We were just saying I hoped we could define good risk disease as IMDC good, oligometastatic disease as IMDC good risk classification. It was 3 votes for and about 15 votes against. So we're unable, it's not defined, it's defined by
But it's not the only thing, but it contributes to it, right? So the
Yeah.
1
So
year out,
it's-
at least 1
It's
year
like
out.
part of the Venn diagram, but not only.
Okay, but we have got somewhere today. We have got somewhere. We're going to stop now, I think, or very, very soon. 'cause
How
I'm
about
dying.
good intermediate and you exclude the poor? Would that be consensus?
Okay. Exclude poor risk disease.
That's good.
But if you have IMDC poor risk disease, you do not. This is the Petros modification. IMDC poor risk disease, you cannot have oligometastatic disease. Who agrees with that? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 32. Who disagrees? Who thinks that if you have porous disease, you can still have oligometastatic disease? Tony. 1. So Tony is 3%. I'm really pleased you came, Tony. So,
But you could, in theory, you could. A
but
bit of
Petros,
anemia.
no, we've got consensus. We've got 90%, Tony. So we actually have agreed. We've agreed on PACE. We've agreed on IMDC. We're not able to agree on sites. Are there any other factors you want to put in? Do we want to vote on the fact that, is there anything around site that we could vote on? Or we've voted 3 times, we were unable to find consensus.
Rank them.
So at the moment we have, it's defined by the pace of the disease, you cannot have good risk disease, but we are unable to come to a consensus on site. Yes?
I think the issue that we're having different opinions because some of us believe it's oligometastatic therapy, but we would also give adjuvant systemic therapy on top of that. So like I have a patient with periodic node, that's the only node I'm doing SBRT, but I'm also doing adjuvant pembro. So if the definition is just local therapy without systemic therapy, then I'm going to vote no. But if the definition is local therapy plus minus systemic therapy as defining oligometastatic disease, then we're going to define it. I think that the hallmark should be that we're going to do local therapy for plus minus systemic therapy. I think that's what the definition should be for oligometastatic disease. But if you exclude the ability to do systemic therapy, then I think the definition becomes difficult. That's my opinion.
We did get a consensus on that first statement.
Yeah, it's true.
So I feel we've covered that bridge, if that's okay.
I'm not sure that not sure that half of this room feels this way, but
We need a recount.
I'm not kidding. Do you want to revote on that?
I would propose a revote. Yes.
Oh my goodness.
Recount.
Sorry, the
I think
different...
an initial
Does the panel agree on a revote?
I think an initial good approach, and then you can define the rest of it, is up to 2 sites, up to 3 lesions, and more than 1 year out from the original resection. That, I think, approaches.
But we never got 2 sites, 3 lesions. We didn't get consensus on that.
Well,
that was your vote.
That's a continued
We
discussion.
can't vote that a second time.
I mean, we have...
Mike, please, inject some sense into this discussion.
I think if we did the 2 sites, less than 3 lesions, excluding liver, and allowing people to get up front or adjuvant systemic therapy, I think there would be more agreement. I think putting brain in there makes no sense because we're going to treat that locally anyway.
And what about the small pulmonary nodule? Everybody thought nothing, and then over the years start growing and remove it. Are you gonna? This is within a year. You're gonna exclude this and not treat it as oligometastatic?
Can we just have
Respond.
one? So I think I'm wondering whether we should put plus adjuvant therapy on the end of this.
Yes,
Yeah.
absolutely.
That's a modification. Mike, are you happy with that?
Hans disagrees.
That makes no sense to me. I mean, first of all, this
Plus or minus adjuvant therapy?
Yeah, but to me, the implication of oligometastatic disease means I can either wait and survey because the tempo of progression is little, meaning doubling time is another thing we need to talk about. And the other one is that just radiation without exposure to systemic therapy risk is amenable. That to me means oligometastatic disease. The other thing that I also don't like is for somebody for intermediate risk disease, you resect it and then you offer, pembro because that's under treatment for somebody with metastatic disease, right? So that's the other thing.
But we are going to vote
So
on
I don't
plus or
believe in
minus
that.
adjuvant therapy. We've had 2 people asking for the vote in the audience. It's still a democracy in the United States of America. So we're going
Oh, wait. You haven't been...
So here we go. We're going to vote. Who thinks we put plus or minus adjuvant therapy at the end of that? Yes, plus or minus adjuvant therapy. 1, 2, 3, 4, 5. Mike, go on, Mike. Use your amendment. 5, 6.
I would say neoadjuvant.
Or adjuvant stroke neoadjuvant. 5, 6, 7. Who's against putting adjuvant therapy there? There's no consensus there, I'm afraid, so we're not including that. It's keeping as it is at the moment. Does anyone want to vote? We've got the PACE, we've got the definition, we've got the IMDC risk, we've not got the sites of disease. We're going to go for a break unless someone's going to say there is a site that we can vote on, an issue that we could vote on for one last vote to see if we could come up. Hans' vote, 2 sites, 2 organs, 3 sites, with the amendment excluding liver and brain, failed, didn't it? We tried that. We tried that vote and it failed. Is that correct?
Yeah.
Has anyone got a better idea, or do we just need to go to a break? David, what do you think we should do? We're going to a break. Thank you very much. We nearly got there. We nearly got there. We nearly got there.
No, we did not.
No, we did.
No, we didn't.
We nearly got